पैर मोड़ लो, वो वाला भी मोड़ लो. So just we were continuing with the rectus sheath. Can I have the linear pro? So I'll give you some of the tips and tricks. Okay. So preserve that twin track appearance and the entry. I can really unfreeze karna. So pointer कहाँ चला गया? मैंने वहाँ रख दिया, वहाँ पर होगा, वो पड़ा हुआ, टेबल पे पड़ा हुआ. So left hand of the screen, my dear friends, is medial, right hand is lateral. Okay. Can you see the three muscles? External oblique, internal transversus. As I go more medial, can you see the linea similaris? And as I go more medial, can you see the rectus abdominis and the twin track appearance? Is it clear? So the nerves are entering from this plane, in between this plane, and traveling upwards like this. The travel upwards is located 1.6 to 2.6 centimeter from this edge. So a good practice is to cover this lateral edge in bulk. So preferably you can come from medial to lateral, or if you come from lateral to medial, be cognizant that this quadrant, the outermost quadrant, is the place where you need to deposit the drug. This is the take-home message which we wish to give you. Another thing is, this plane is quite vascular. Always switch on color before actually attempting this block. Is it clear or not clear? So another thing which I said was, below the umbilicus we have the arcuate line. How do I identify? ऐसे रहना. चलो डालो. अरे इधर डालो दोस्त. तूने पैंट बंद कर ली अपनी. पैंट खोलो. एक सेकेंड इसको कवर कर देते हैं. So I'm right in the midline, just below the umbilicus. Okay, I'm moving one side to the lateral. Can you see the twin track appearance still there? Okay, I'll keep moving down. A point will come, this double appearance will disappear, and only a single line will be reflected back. Can you see only one line is there? Can you appreciate only one line is left? I go back up 2 lines, I go back down 1 line, I go back up 2 lines, I go back down 1 line. So I have reached the arcuate line level. Somebody asked you, how do you identify arcuate line? This is the arcuate line. This is almost close. If you see my finger, इस तरफ से camera, एक second, I'll get my finger here. This, if you see, I am almost close to anterior superior leg spine. So close to ASI is transversely the arcuate line is there. So if I have to perform the rectus sheath block in the inferior quadrant, it has to be between umbilicus and the arcuate line. Okay? Or alternatively, I can, if there are a lot of dressings, I can move laterally, linea semilaris. I can see 3 muscles, external oblique, internal and transversus. Between internal and transversus, I can do the so-called older version of anterior tap, which would again take care of the anterior cutaneous branches. Is this concept clear? So now I'll tell you something about tap. You must have heard the terms lateral tap, subcostal tap, posterior tap. What is the modern day nomenclature? Only 2 taps are there, subcostal tap and the mid-axillary tap. So subcostal tap, as the name suggests, what happens? I am going to perform parallel to the costal margin. So okay, so I feel for his xiphisternum, I have kept my probe parallel to the obliquity. Can you appreciate 2 muscles? Left hand of the screen is medial. Can you appreciate rectus abdominis? Underneath is transversus abdominis. The external oblique is not present here. Why? Because it has become epineurotic. Okay, internal oblique is not there. It is replaced by rectus abdominis. As I keep moving laterally, my dear friends, laterally again, what would I encounter? The linea similaris. Have I reached the linea similaris? The answer is big yes. I go more laterally, I encounter 3 muscles, external oblique, internal and transversus. So what is the tap plane? Between internal oblique and transversus. But medial to the linea semilaris, what is the tap plane? Between the rectus abdominis and the transversus. So if I have to catch hold of T6, T7, I will have to be more medial to the linea similaris. At the level of linear semilaris, T8 would be there. Lateral to that would be T19. So if I have to block the lateral cutaneous branches, so called from T6 to T10, I have to inject medial to linear semilaris also, as well as lateral to linear semilaris. So can one injection suffice? The answer is yes. I can start from this place, keep hydrodissecting, and keep moving medially. At times, hydrodissection just medial to linear semilaris would not be possible. In that case, I can withdraw my needle and do a separate injection. Or alternatively, I can start from the midline here and keep injecting down. So this completes my subcostal tap, which will take care of the T6 to T10 branches. Is that okay? Clear? Not so clear? Yes. Very nice. So now coming on to the mid-axillary tap. Okay. So mid-axillary tap, let's start from the close to umbilicus. Can you see the umbilical shadow? Can you see the rectus abdominis? Twin track appearance. Okay. I keep moving laterally. I encounter linear semilaris. Then three muscles. External, internal transverses. Beautifully seen? हाँ या ना तो बोल दो दोस्तों. Internal oblique is the thickest. Can you appreciate? Transversus abdominis is the thinnest. Internal oblique is more hyperechoic. Transversus abdominis is more hypoechoic. That means black. Okay. And if I move my probe like this, cranial caudal, what is happening? External oblique and internal oblique are moving in opposite directions. So this is another way to identify these two muscles. I move laterally, my dear friends. Internal oblique and transversus abdominis, I keep falling towards mid-axillary line. Okay, heel to maneuver. Can you see the transversus abdominis ending? Can you increase the depth, Shrikant, please? Can you see transversus abdominis has ended? Okay, so where it is ending, just prior to that, if I deposit between internal oblique and transversus abdominis, this is the mid-axillary tap. The older nomenclature was the lateral tap. And we should be going as posteriorly as possible with a hope to catch the lateral cutaneous branches of the thoracoabdominal nerves between T10 to L1. Is it clear? If I go more posteriorly, my dear friends, and increase the depth, can you see the white hyperechoic line? Can you freeze it? Okay. So this white hyperechoic line, my dear friends, represents the common aponeurosis from the internal oblique and the transversus abdominis. This white hyperechoic line underneath has a thin white facial line which represents the transversalis fascia, which is the general investing fascia of the abdomen. If I get my needle from this place and deposit the drug between this common aponeurosis and the transversalis fascia, the transversalis fascia will move down. It becomes the transversalis fascia plain block described by Peter Hubbard and colleagues in 2009, specifically designed to target the ilioinguinal, iliohypogastric and the subcostal nerve. Very good block for doing anterior iliac bone crust harvesting, and it can serve as an anesthetic block also, which we have done at times. Is it clear? So we have tap here, we have transversalis fascia plain block here. And if I go more posteriorly, what muscle you will visualize? The quadratus lumborum. So the lateral quadratus lumborum and transversalis fascia plain block, my dear friends, is almost serving the one and the same purpose. So I will try to show you once again where we are. Really. So can you appreciate external internal transversus? Transversus is the first to end, okay, first to end. Now what Shrikant has done, can you see from square shaped we have gone into a trapezoid shaped. So he has utilized the virtual convex function of the PX machine. It is not available in the inferior models. So this is the beauty, we can get a wide view so that he has understood what I am trying to show is quadratus lumborum, which is possible in this linear probe. Otherwise we will have to use a curvilinear probe. I go more posteriorly, my dear friends, more posteriorly. Maximum depth है और depth बढ़ाते चले जाओ. हाँ और बढ़ाओ. Yes, almost I have reached the level of quadratus lumborum. This muscle is nothing but quadratus lumborum. Okay, and this black area you see, this represents the pararenal fat a part of the retroperitoneum. So I'm applying thoda pressure laga raha hu bhai, over pressure lagata hu so that I can show you the QL. This is the quadratus lumborum, my dear friends.
I think so. In this view, in this particular view, we can see the transverse process as well as the.
I am trying my level best.
And this is the QL muscle. This is the psoas muscle.
Can you appreciate? With linear view, it's not possible. इस बेचारे को बहुत
दर्द हो रहा होगा.
कष्ट हो रहा होगा. अभी मैं आपको curvilinear से दिखाता हूँ. देखिए कितना better हो जाएगा.
So we can give QL block in the supine position also.
Yes. Thank you. So are the abdominal wall blocks clear to you? We are left with EOI block, which I will show you. अभी मैं quadratus lumborum पूरा कर देता हूँ.
So one more question I can ask you.
Yeah, please.
Is the FTP block good for cesarean sections or the TAP blocks?
Excellent. So FTP block, in my opinion, is slightly better than the TAP block. And we have done a DNB thesis, we have completed it, where FTP turns out to be better than. Why? Because we are selectively targeting ilioinguinal, iliohypogastric and subcostal, and the phalansteal incisions happen in that region. Whereas TAP, we do not know whether we are going to capture these nerves, because they are not running discretely, they are running in the form of plexus. Can you increase the depth, please?
Forming the FTP block in the supine position, or you are turning the patient little lateral to
supine.
So only in the supine position in the linear probe.
Can you appreciate the shamrock sign in the supine position, my dear friends?
1, 2 and 3. Yeah.
Okay. So the lateral QL would be on the lateral side. Anterior QL would be between the psoas in this plane. Okay. Posterior would be posterior is like. Okay. So ideally, if I have to do, I would turn him laterally. एक बार करवट ले लो. So then the appearance of quadratus lumborum is going to change slightly.
Yeah.
But we will be able to recognize the thumbs up sign.
QL is a thoda vascular muscle. The vascularity is a little more. So the QL is slightly hypoechoic as compared to the psoas.
Can you appreciate the hypoechoic quadratus lumborum muscle? Please, Karna, this is my favorite block. You cannot go wrong in this. Okay. So just freeze the image, please. Okay. So my dear friends, this is anterior, this is posterior. So my needle can come from anterior to posterior or posterior to anterior. As a beginner, I would advise you always come from posterior to anterior, because anterior to posterior, this is the pararenal fat. And I'll show you, if I go a little cranial, my needle could come through the kidney. I'll show you how the kidney looks like. So it's a volume block. We give 25 to 30 ml of 0.3% ropivacaine with dexamethasone. If I have to give bilateral blocks, as we do for TLH, we add 5 microgram per ml of adrenaline. On the posterior surface, there are certain vessels. First, switch on the color so that you do not go accidentally wrong. So if I get my drug here, this is lateral QL. If I get my drug here, this is posterior QL. If I get my drug here, this is anterior QL. Is the concept of quadratus lumborum block clear? So can we get him supine? Seedha ho and linear probe. Now I'll show you the external oblique intercostal facial plane block. Okay, this will finish our trunk blocks as well as abdomen in its entirety. The popliteal sciatic we have already covered. Now we'll switch over to the lower limb after this and then come back to the upper limb. It's 11:30. We have still 1 hour. So any other particular block, if you are interested in knowing.
So there is the talk of the town nowadays, the M-TAPA block. The TAPA and
M-TAPA will show you, but I am personally not convinced. So I still, you know. Huh?
I also.
So EOI is much better than M-TAPA. Okay, I'll show you. So
the EOI even is a better block if you are getting the hepatectomy done with the same side incision.
For Whipples, what we have done, we have stopped placing epidurals. We place the EOI catheters for Whipples. Excellent results, because with the epidurals, what happens? Hypotension slightest. It goes to the critical care team. Critical care team is separate from us. They'll bring the anesthetist. Kaisa anesthesia dete hain, inka hypotension. They're very fond of fentanyls. So I don't want that mess. I place EOI catheters. Beautifully, it works. Go down.
So what we are doing, we are putting in the epidural catheter
with morphine.
With morphine, you know,
Yes, we can do that.
But for the delegates, I must tell you, we are putting in the epidural catheter when we attach the pain pumps in all our laparotomies. But for day 0 of analgesia, we are giving EO-IO block. We don't start the epidural on day 1 because of the same complications, you know, the hypertension and, you know, other developments.
So my dear friends, EOI is done approximately at 6, 7th, 8th. They are ready with the live session. अभी फिर करते हैं थोड़ी देर.